Hi, guys. Welcome to A Little Help for Our Friends, a podcast for people with loved ones struggling with mental health. Hey, little helpers. It's Dr. Kibby here. Before we dive into this episode, I wanted to tell you how I could help you navigate the mental health or addiction struggles of the people you love. Cool of Mine is the online coaching platform and community that I built to support you in the moment when you need it the most, like having hard conversations, asserting your needs, or setting boundaries. Even if you're just curious and want to chat about it, book a free call with me by going to the link in the show notes or going to coolamind.com, KULAMIND.com, and click Get Started. Thank you and enjoy the show. Hello, little helpers. Today I'm going to be talking about complex PTSD or post-traumatic stress disorder. The reason why I'm talking about this today, it's interesting. I had no idea how much I hit on a really sore subject. I was posting on Dr. Kibby, my Instagram account, that I'm just kind of new to Instagram, and I'm, just trying to get the word out about different mental health disorders and things like that. You know how I do. But I posted a skit that I did about diagnosing borderline personality disorder. And I had a couple of videos, and the first video that I did was on some of the emotion dysregulation traits of BPD. So the skit was, silly. I didn't know really what I'm doing, but it's showing me doing, as a therapist, doing the SCID PD interview, which is a established semi-structured interview that we use to diagnose different disorders. So I'm basically like reading out these questions, and then I am also acting as like a patient, like a stereotypical patient. And in this one video, I talk about the emotional ability, so the ups and downs of emotions. And then I talk about difficulties controlling anger, so anger outbursts that might lead to like violence or anything like that. And then dissociation. So that video just had like those traits. And I was surprised. I got some hate. I got some trolls that really didn't like the video. A lot of people liked it, but some people were like ripping me to shreds. And I mean, that never feels good, but it's really interesting when I get hate on a video that I didn't really mean to be controversial, because it makes me learn something. It makes me learn, like, how are people thinking about these disorders or the content that I'm talking about. It makes me question my own bias in terms of how I see these disorders. So I actually appreciate when people, when things get heated. I'll put the link to the actual reel on the show notes so you can see what I'm talking about. And I'd love to hear your opinion after all this. But what I saw was that there were a lot of people, I think some of them are counselors, but who knows? But some people were so mad that I wasn't talking about trauma in that video. And I was kind of like, well, I can't cover everything about BPD in like 1 minute Instagram skit. It's so stupid. It's just meant to start a conversation, not really like to show everything. But people really angry about it. They're like, how could you not talk about trauma? These are all symptoms of CPTSD. You were being inaccurate and harmful and misrepresenting a really, patient's experiences. And I was confused because I was like, what did I do wrong? I kept saying, hey, yeah, these symptoms of emotion dysregulation can be seen in a lot of different disorders. I'm not saying that. And I'm also saying that trauma is a big part of BPD. I don't understand what was going on. But thinking about it and like really taking in the comments, it really seemed like the diagnosis of borderline personality disorder was stigmatizing, was something that people really, really thought that there was like me or a psychologist making a judgment call saying that something's wrong with the person or they have a bad personality, whereas it's miscasting these symptoms as symptoms of trauma, which I guess were seen as like more favorable or more empowering or less stigmatizing. So, it really made me think like, oh, it's interesting how we might be at a point where trauma-related disorders is seen as less stigmatizing than like personality disorders like BPD or even narcissistic personality disorder. But honestly, they are mixed together a lot. So it inspired me to say, okay, let me talk here in more depth, not just on Instagram comments, but let me talk here to you guys about what CPTSD is and how it's related to borderline personality disorder. And so I did a little bit more digging, a little bit more digesting, and then I'll also talk about what that means for treatment. Like if someone has CPTSD or if they have BPD, how do you treat it, right? And so I'll start by describing what complex PTSD is. And I was actually surprised when I looked, I didn't know this, when I looked in the definition, the diagnostic criteria for CPTSD, I was surprised to see that it isn't recognized in the DSM-V. The Diagnostic and Statistical Manual, edition 5, that we all base our diagnosis on in the field, doesn't recognize complex PTSD. Of course, there are other trauma-related disorders, but it's not in there. It is in the International Classification of Diseases, the ICD framework. And that's just, basically something that we use to bill insurance, diagnose people. So CPTSD is in the ICD framework, whatever that means. I think it's because that the research on all of this is still like growing. So we don't know a lot about it. So let me just explain what are the symptoms of complex PTSD. How is complex PTSD actually diagnosed? So the first thing is, as you imagine, the patient has to report experiencing a trauma. That's a hot button issue on itself. So let me explain. I'm literally going to read out what it says from the DSM-V, the guide of like what trauma is, how they define trauma. Exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways: directly experiencing one of these, witnessing another person go through this, learning that one of this happens to a close family member or friend, or, having a loss of a family member or friend, and also experiencing repeated exposure to aversive details of the traumatic event. So, watching the police deal with it, or, things like that, right? So I understand that the definition of trauma in the official DSM, it's really, really limited. It's exposure to actual threatened death, serious injury, or sexual violence. So it really is very specific of if you've experienced something that has threatened your physical safety and life, right? So usually that's, of course, sexual assault or being beaten or natural disasters or war or getting in a serious accident, right? All of those are considered capital T trauma, where you're afraid of your life, where you're afraid for your life or someone else's life. Of course, that might not always represent everything that we feel is traumatizing, right? Outside of the DSM, psychologists will think about trauma as anything someone goes through that is upsetting, negative, and overwhelms the person's coping abilities. So it's something that you go through that's really difficult that you can't cope with. So, of course, some people, if you've been physically abused, capital T trauma. But a lot of people experience other things as trauma, like a lot of emotional abuse, right? Or microaggressions. For example, something that really overwhelmed my abilities to cope was telling my mother how I felt about things, like telling her that something was hard or I felt really sad or scared or whatever, and then she'd talk about herself and her emotions. So that happens a lot. Did I have a capital T trauma? No, but over time that, I guess that hurt me, right? It kind of gave this, it built this belief about me as, my feelings don't matter. So it's really about someone else and how they feel and how I'm attending to their feelings. And so that really gave me a low self-esteem. And when I look back, I feel very sad. I feel very angry about it in ways that I didn't in that moment and didn't know how to cope in a way that was healthy, right? So, but also, like people have experienced other like microaggressions of their culture as trauma, right? I mean, a lot of people are experiencing like capital T trauma now about that, but growing up when people were saying ching chong chang and making fun of my slanty eyes, like, did I have a capital T trauma? Did I feel like I was threatened for my life? No, but that I didn't know how to cope with that, right? That wasn't that I experienced that as negative and it impacted me. So, I don't go around saying that I was traumatized by these things. I do have capital T trauma, but I understand that a lot of people might develop trauma-related disorders or other disorders when they have trauma that isn't as like loud and obvious as something like physical assault, right? So, or sexual violence. I mean, the range of what sexual violence can mean can be so different, right? You could have like really, really clear, like being sexually assaulted, but sometimes it's unclear, or it's something that just made you feel a certain way, or you weren't able to cope. I mean, I think I'm getting almost defensive because I get that having trauma and having experienced trauma as a main criterion for diagnosing trauma-related disorders can feel invalidating, right? If someone is experiencing PTSD or trauma symptoms, but they weren't threatened, they didn't have any of these like capital T, like exposure to threaten or actual death kind of trauma, they could question themselves and feel like, oh, what I went through is not that bad and I don't know what's wrong with me, right? So let me just say that officially when we're like writing in our, it's really about like insurance and communicating to other providers what a person has. So when we give like that diagnosis on a chart, someone has to have experience or reported experiencing one of these threatened death, serious injury, or sexual violence trauma in order to be then diagnosed for PTSD or trauma-related disorders. Okay, so the first criterion for CPTSD, experiencing a trauma. Now, often in CPTSD and complex trauma, it is not just one event, right? So it's often something that someone experiences over time, like being tortured for long periods of time, or repeated abuse from a caregiver, right? Or being systemically oppressed. So it's something that happens over a period of time, right? And that's tricky because that means that a lot of people with CPTSD, this is how they grew up, right? They were in dangerous environments. They had really abusive caregivers, right? And so that really shapes who they are, their personality, right? And it shapes the way they see the world. So usually this kind of trauma is repeated, not just one event. Or if it is one event, it's really, really bad and really affects their whole life. So in addition to that exposure to trauma, especially repeated trauma, people with PTSD, complex PTSD, often have kind of the classic PTSD symptoms. So re-experiencing, where someone has intrusive memories, flashbacks, or nightmares, right? Repeated nightmares, repeated flashbacks, like as if they were back there, like something might remind them of like smell or hearing about something that reminded them of their traumas, and then they feel like they're there, right? Or just having a memory pop up in their mind over and over again, even when they're trying to, not think about it. Avoidance is a big one. Avoidance of anything that reminds that person of the trauma. Avoiding places and people and situations. Sometimes it gets so bad that they, will obsessively do something or keep busy in order to stop thinking about it, right? Like watching TV, scrolling, binge watching Netflix, compulsive shopping, or just staying busy, being workaholic so you don't think about that memory, don't think of the trauma. And then threat perception, which is always being on the lookout for danger, always feeling a little jumpy, always looking out, being hyper aware and looking around the room and constantly scanning for danger. So those are more classic PTSD symptoms. So here is what makes complex PTSD a little different. There are a set of symptoms called disturbances in self-organization. And those involve emotion regulation, your self-concept, how you feel about yourself, and relationship functioning. So examples of, let's say, affect regulation, emotion regulation, is really having intense emotional reactions. When something reminds you or upsets you and reminds you of that trauma, you get really, really upset, really angry, really sad, really scared. Self-destructive. So that could look like several different things. Could look like self-harm, could look like doing things that are risky or dangerous, like drinking or something like that. And dissociation, right? Dissociation, we talked about this before in this podcast, but dissociation is the metaphor we like to talk about is when your computer gets too hot and overheated, the fan turns on and it kind of goes to sleep, right? It's like, it's too hot, there's too much going on, I got to cool down. That's kind of what how we psychologists think of dissociation in the brain. When something is too upsetting, it's too painful to handle. The brain has all these mechanisms of protecting itself, meaning it'll blank out. You kind of feel blank or foggy, or like you're going through the motions. You feel outside your body. Time is moving slowly. You might be really disoriented, and you might even completely lose time, completely lose that memory. That's the brain going, I really can't handle what's going on. I'm just going to go to sleep, so to speak, so that I'm going to protect you from this memory. So that's what dissociation is. The self-concept domain, the self-concept type of symptoms and disturbances of self-organization. Self-concept is really just like a persistent low self-esteem, feeling deeply worthless, defeated, helpless, feeling guilty and ashamed about the trauma, like I should have left, it's my fault, I'm broken, I brought it on myself. So I see this in PTSD too, but really just feeling on the inside that you feel really bad about yourself as a result of the trauma. And then relationship functioning. So relationship functioning is significant difficulties in sustained emotional intimacy. So what that means is, what I've seen is people who have a really hard time getting close to someone. Whether that means they have a hard time dating and really, going deeper in a relationship, have a hard time opening up, being vulnerable, trusting other people. So usually it looks like an avoidance. Sometimes it could look like anxious attachment, where they're kind of chasing the approval or belonging to someone. But usually it's like this kind of emotional numbing and blunting around intimacy, having trouble with sex and everything like that. So these disturbances of self-organization, that is a little bit more like the personality kind of stuff, right? It's like it affects the way you feel, it affects the way you see yourself, and affects the way you get close to people. So having long repeated trauma over the course of your life can change the way you see yourself, change the way you feel about yourself and love and attachment to people. So you might be thinking, okay, well, how do you know if you have PTSD or complex PTSD? Like, how complex is my trauma? Well, usually, especially because people who have complex PTSD have like long history of trauma, it's often worse, right? So there really isn't that much of a difference between regular PTSD and complex PTSD, except that it might be more severe and more pervasive in your life. So you might, instead of PTSD might affect a certain time, like, oh, you might be experiencing PTSD symptoms and having a lot of nightmares a certain time of your life. Complex PTSD, clinically, it feels like it's woven into the way you live your life. As you can imagine, when you go through a really long, maybe early childhood trauma, it shapes who you are. So you might have a really hard time getting close to people, whereas people with PTSD, it might be just when the PTSD symptoms are kind of um, on fire or like triggered, right? So complex PTSD kind of looks like it really affects a longer period of time and across different areas of your life, like with your relationships, um, romantic relationships, friendships, at work, and things like that. So it's a little bit more pervasive. But the disturbances in self-organization are really the key differences between someone who has PTSD and complex PTSD. So that means when someone has a lot of emotion regulation difficulties and has a really almost like stable negative self view of themselves, like a really persistent, really chronic low view of themselves. Like they really see themselves as bad or broken or inferior or at fault for the things that happen to them. And relationship difficulties, like avoiding being close to someone, feeling detached. Those disturbances in self organization are really the things that pop out as, like, oh, this person has complex PTSD. So the tricky part is that complex PTSD doesn't have a lot of good measures out there, which it really surprised me. We have really good measures of PTSD and other disorders, but complex PTSD is hard to diagnose because I don't know. I don't even know what's going on, but I guess we don't have enough of these measures. So I'll give you an example of what, I've seen complex PTSD in some patients and people. I might have complex PTSD. When you think about it, like the stable. Well, I am fine getting close to people, but the negative self view is something that I struggle with, and at times I've struggled with affect regulation. So yeah, I might have complex PTSD symptoms. But when I've worked with people with complex PTSD, they usually had a really, really difficult life. I could think of like two or three patients that I miss and I loved. They were just so wonderful in so many ways. But this is just these three people. Okay, this complex PTSD could look a bunch of different ways. But these people were abused as children. Like one of them went through repeated sexual trauma from a parent, and the other one, um, the family had a lot of addiction issues, and then she ended up starting to date and marry someone who had addiction issues. So there was a lot of like in and out of the hospital, like someone about to die, right? There was a lot of trauma for all of her life. So these people were shaped by that, were shaped by growing up in a tough world. And what that looked like was they had all these beliefs that were so hard to talk them out of. Like, everyone's out to get me. No one is safe. I can only trust myself. I can't get close to anyone or tell them what I feel or what I'm really like because they'll use it against me. Um, Ironically, all of them, not ironically, but they all were dating. They all had relationships. They all were very good at their jobs, right? That there's another thing that might be a coping mechanism of like being really good at work or being successful in certain ways so that people don't, I guess, as to compensate for the trauma, right? A survival mechanism. They like learn to survive by being really good at their jobs. Um, they were charming. They were lovely. They're really kind people. Um, they had relationships. As I said, one was married, but they all felt like they didn't their partners didn't know the real me. I couldn't let them get close. I didn't, sex was difficult. Sex was something that they avoided or felt like it was just, they could maybe dissociate or they're out of their bodies. So they felt like there was some kind of wall in between them and the people that they loved, which was really hard because they felt really lonely. They felt very like, I wish I could really feel cared for and close to someone, but I can't trust people because what if they leave? What if they die? What if they hurt me? And that was really hard to, cognitive therapy, we try to like talk about, oh, is there any way to see this situation? But they're like, no, I've had this in my entire life. And anytime I'm close to someone, I love someone, they hurt me. It's like, okay, well, then that is what that is the way they see the world and relationships. And it's so hard to change. Not that it can't change, but it was just ingrained. They were like, yeah, obviously, everyone knows you can't trust anyone. Like, ooh, oh God. No wonder why you're lonely. That's tough. And the dissociation piece was really big with these patients. One of them, I think most of their day they couldn't remember. They were dissociating like, first of all, a lot, like people with CPTSD commonly don't remember a lot of their life, especially when they were exposed to the trauma. So it's one of my, the spidey sense when I hear someone say, yeah, my childhood was a blur. I don't really remember a lot of it. I remember flashbulb memories of like scary things that happened, or maybe like one memory that's nice, but most of it I can't really remember. I'm like, uh-oh. Yeah, it's hard to remember childhood, right? We're so young, but when it feels like a blur, or there's a like an ominous feeling, like when they look back on their childhood, it wasn't a blur because like, oh my gosh, it was so long ago, but if like, ugh, I knew my childhood wasn't good. I can't really remember why or what happened, but I just don't want to think about it. That's a sign for me of like, oh dear, this person went through a lot of hard things. Um, and sometimes that happens in their current life where their mind is like a little fuzzy or can't remember a lot of things or shuts off, or they get a little spacey when things get really stressful. So the dissociation piece is a really big part of complex PTSD. And I'm still chewing on why people on the internet got so mad when I showed signs of, my reel talking about emotion dysregulation and said these are symptoms of borderline personality disorder and not CPTSD. I didn't actually say that's not PTSD. I said these are signs of BPD, and they were like, "How dare you? This is clearly trauma," and CPTSD. And I'm like, I also want to say here on this platform that I don't agree with treating one disorder as better than the other. I know that when you get a diagnosis, it can change your life in good or bad ways, right? You get a diagnosis and it could explain why you're having all of these symptoms. Or people start to identify, like, oh, I'm someone who has X, right? Oh, I have autism. That is why relationships and social interactions have always been hard. So it can be tough, but also really relieving because it's like, there's a word for it. We could label it. Sometimes those labels are scary, right? So I think BPD is one that tends to be scary. I realized through all that hate online towards me, I realized that I have been really privileged and have a bias. I have a I grew up as a psychologist in all of these settings, these institutions that had really good research and treatment for personality disorders, right? This is what I wanted to learn. So I went to Duke that has a DBT program, right? A dialectical behavior therapy program. I'll talk about that in a second. A lot of research on borderline personality disorder. So there were a lot of us therapists and researchers who were there because we loved BPD, because we had people in our lives with BPD. We had struggled with it ourselves, or something about it that drew us to it. So bias was like, we were around people. I learned psychology being around people who were like, oh my God, borderline personality disorder. Tell me everything about it. Oh my God, there's a patient with BPD that wants to see a therapist. Let me see them, right? BPD was seen as, we understood how hard it is, but we didn't have as much stigma around it as other clinics must, right? Like if someone came in with a diagnosis of borderline personality disorder to Duke, or if someone came in with complex trauma, I don't think we would treat them any differently, right? We wouldn't be like, oh, well, the BPD patient, that sucks, I don't want to treat them. Like, no, we wouldn't. So, and then I went to internship at Weill Cornell, the Personality Disorders Institute, where they were all about borderline personality disorder and narcissistic personality disorder. My goodness, we love talking about it. We love thinking about it. We love treating those patients. So I will say here that I'm really biased, and I did not feel and was exposed to as much of the stigma against borderline personality disorder as maybe in other community settings or how some patients have experienced it, right? So I get that some people have gone to hospitals or doctors, gotten a diagnosis of borderline personality disorder, and then they themselves feel hurt. And maybe there's some doctors who think badly about that. I think that's horrible, but I can understand that having a quote personality disorder is very shaming. And I really wish that one day we could change the name of those to something that's a little bit more, that's a little bit less like there's something wrong with you as a person, and just like there are unhealthy patterns that you keep doing for a long period of time in your life that isn't working anymore, right? That's really what personality disorders are, is that you've coped in a way that has worked for, maybe your traumatic childhood, but isn't working anymore. That's it. We just call it personality because it just is, it describes something that you do across time, like a lot of your life, and across different situations, like home and work and in romance and things like that. That's all we mean by personality disorder. It doesn't mean that you're an asshole or anything, which is, I get, like if I had that diagnosis, I'd feel that way. So just want to say, like, I get that there is different feelings about the diagnosis of complex PTSD and borderline personality disorder. I hope that something like this episode can contribute to an understanding that there's not one that's better than the other. If literally a patient came in to see me and they had a diagnosis of CPTSD, or another one came in with a diagnosis of BPD, I would be equally happy to work with either of them. I would not have a judgment either way. So I hope that I hope that we as a field can move towards that. Because I didn't even know this. I didn't even know that there was like anyway. Okay, so that's me saying mea culpa and apologizing for saying these are symptoms of BPD and not realizing that could be really triggering for some people. So what is the relationship and differences between CPTSD and BPD? Because even me, who's like obsessed with learning about emotion regulation, I'm like, wow, those disorders are really similar, right? You have problems regulating emotion, like when you get angry, you get really angry. And when you get sad and depressed and anxiety, like everything seems to be dialed up with emotions. A lot of anger involved. Of course, if, with both of those disorders, you can feel very angry and cope with life with like really explosive anger. Having the view of yourself, like having low self-esteem is common, and problems with relationships, right? It's like both of those disorders have a lot in common in dissociations. There's a lot in common with BPD and CPTSD. These acronyms are CPTSD and BPD. Anyway, so they're very similar. And I totally agree that if some patient were to walk in and say, hey, I'm going through a lot of my relationships, I'm fighting with a lot of people, my emotions are all over the place. Like when I get sad and angry, I really like explode, but then I feel really bad about myself. And sometimes when I'm really upset, I kind of blank out a little bit. Those two people, like that person it's hard to say what they have, CPTSD or BPD. It could look similar. Now, but I looked very carefully, and here are the differences according to the research. In complex PTSD, dissociation and persistent major depression is more common in CPTSD than BPD. So, of course, because there's trauma-related disorder, there's more blanking out. There's more losing time. There's more like I can't remember big chunks of my life. And also, it feels like CPTSD is like there's more low-level stuff, right? There's more low mood, depression, low self-esteem. That's one of the things that really surprised me in the literature about the difference between borderline personality disorder and complex PTSD is that people with CPTSD tend to just feel bad about themselves all the time. They feel numb, they feel low, they feel broken, right? They feel withdrawn or shut down or numb. So this like, this more of a persistent protection mode, whereas BPD is a little bit more up and down. People with BPD can have like long periods of time where they're depressed or feeling bad about themselves. I'll give you that. But there's a little bit, BPD feels like a little bit more like a roller coaster or like fiery, right? There's a little bit, they might feel really good about themselves when they feel connected and they feel loved by someone. They're like on top of the world, like, oh, I feel so good. But then when things go bad, it really goes bad. They feel bad about themselves and they feel ashamed and everything like that. So there's a little bit more like an up and downness with BPD than in CPTSD. So I stand by what I said in my video. I was showing emotional ability of like when someone is like good, they're really good, and when they're down, they're really down. It can fluctuate throughout the day based on what they experience. They get they have a really nice morning with a friend, they could feel on top of the world, but then they get a text from their boyfriend that's rejecting or critical, or that person withdraws, and then everything is down and bad and I'm bad, right? So this kind of like all or nothing, up and down roller coaster is a little bit more characteristic of someone with BPD. Also, with someone with BPD, there's a little bit more self-harm and suicidality. Not to say that CPTSD doesn't have that, but in BPD is a little bit more. So that's like the main differences between CPTSD and BPD. CPTSD, I keep wondering if I'm like messing up and saying this wrong. CPTSD has more depression, more persistent low self-esteem, numbing, and feeling shut down and withdrawn and just dissociated. So they're like more checked out, withdrawn in protection mode. People who have borderline personality disorder, BPD, it's more of this up and down. Like, I love you, I'm very, very close to you, but then I pull away. I feel really good about myself. I feel terrible about myself. I feel really good today. Oh my God, everything's the worst. So it's just more volatile, more up and down in BPD. However, of course, both kinds of people with those different disorders can have trauma, right? It was so funny. There was one comment that was like, how could you talk about BPD without talking about trauma? And I said, because trauma is not a criterion for borderline personality disorder. And they were like, how dare you say that people with BPD and all the emotions and the anger isn't because of trauma? I'm like, no, wait. wait. They can have trauma. And often people with BPD, people with all sorts of disorders have trauma, right? Trauma is a cause. Trauma is a risk factor, right? But in trauma-related disorders, you have to have a trauma. That's one of the criterion, right? You have to be able to say, yes, I went through something that threatened my life. I went through a major accident. Someone beat me, right? You have to say that has to be present. Whether you remember it or it's reported somewhere, you have to say, I had these symptoms after something terrible happened to me. That could also be the case for other disorders, right? Like someone can develop BPD bipolar disorder, OCD, anxiety after a trauma. But those can be diagnosed without knowing where it came from. So those disorders are a little bit like what's going on now versus where it came from. I'll give a little analogy here. And I apologize for any medical providers listening to this because I'm going to sound like an idiot. My husband right now, oh, but my husband right now has a herniated disc. He has a little back problem, which I'm finding is really common among young men. So I don't know what's going on in the world, but we need to fix everyone's backs. But he was having an issue with his back, and it was affecting his legs and his walk and everything like that. What they what could have happened was that the symptoms of the back pain and the leg numbness, tingling, or whatever, those were the symptoms that we're talking about. This is the problem. But we don't know where it came from, right? There could be a trauma, meaning there was one event where he lifted up something heavy, and actually, he did. He was at a party and he lifted up a big table, a coffee table, and he felt like in his back. So it was like an event where his body couldn't cope, right? So it was like that was the trauma, you know. But you could also get problems with your spine by every single day having some kind of pattern that leads to the problem. Like if you're like right now, like I'm slumped over, right? Like I'm curving my back. So, and a lot of people sitting over a desk, it's really hard in your lower back. And a lot of people get herniated discs just because of bad posture. You wouldn't say, oh, they have a trauma, but like 1,000 paper cuts over time, right? 1,000, like every day having a little wear and tear on your back can lead to a herniated disc, right? So that's what I mean by when we talk about borderline personality disorder, they can have trauma. They usually do. But we don't have to say, oh, they've had to experience threat of death, seeing someone die, or sexual violence or whatever in order to get the diagnosis of BPD. You need to have that in order for a diagnosis of PTSD disorders and related disorders. Hope that makes sense. This is really going into the weeds of the diagnosis, but I think it's important. But then you're like, what happens if you can't remember the trauma? It's really complicated. Yeah. Yeah. In a lot of these scenarios, it's like, I didn't even know that was traumatized. I didn't even know I was abused, right? My childhood is a blur. I don't know. Um, these are the situations where a diagnosis doesn't really matter. Like, it's helpful to know if you are coping with the memory of something. If you are going through something hard and having anger outbursts or dissociation because something is bringing up memories of something you experienced in the past, even if you can't remember it, but it reminds you of that and it's like bringing all those feelings back, that feels like more of a trauma symptom than BPD, where yes, that all happens too, but sometimes not. Sometimes it's just about dealing with stress or negative emotions, whether it reminds them of their trauma or not. So basically you could have whatever you have either one you want, and it doesn't mean anything good or bad. So I'll give an example of what it could look like to have borderline personality disorder without trauma. Rare. It is rare, right? As I said, capital T trauma and the DSM-5 is like, oh, I was afraid of my life. But often emotional abuse, being yelled at, criticized all your life, that's traumatic, right? So someone with borderline personality disorder could have that. Like they were yelled at or called bad or judged or, rejected, felt othered when they were growing up. I have seen some patients with BPD who even they themselves were like, I had a great life. I don't think I'm traumatized, but yet I'm a mess. I'm like, doing a lot of drugs. I can't have a relationship. My emotions are up and down. often those people were born with intense emotions, right? They feel deeply. They have a lot of reactions, emotional reactions. They cry easily, right? Beautiful emotional depth. And growing up, they just didn't learn how to regulate it, whatever that means. Sometimes that looks like someone with a really nice family that the rest of the family just didn't have as intense emotions, right? They're like the one person in the family that's like the emotional one, the artist, the quote dramatic one. And the family might be really nice, but they didn't know how to deal with it. So they'd be like, I calm down. Are you okay? It's gonna be fine, right? That it could be invalidating and to the kid who is feeling intense emotions. Um, and that's traumatizing in the sense that they were feeling intense emotions. They were really upset and no one was there to help them cope. And they didn't know how to cope in that moment. So it was overwhelming. And someone could look back and be like, yeah, my childhood was pretty normal. I wasn't assaulted, I wasn't beaten, my parents were around. They just didn't really understand me. So that is what it could look like when someone has BPD without like capital T trauma. But they could feel like those moments that they were invalidated or misunderstood or dismissed, rejected, traumatizing. And that's totally legitimate. Okay. So I'll say that. But okay, so what does this mean for treatment? If you're like, oh my God, I think I have, I think I have a symptom of, I think I might have CPTSD or BPD, whatever I'm talking about here. What does treatment look like? And that's really where the diagnosis is important for us psychologists. It's not necessarily like, oh, this is good or bad, or oh, this can be treated or not. This is like, how do we treat this person? If I have someone with BPD versus CPTSD versus anxiety versus schizophrenia, that means that I'm going to treat them with different things, right? Especially if it goes on the record. And usually it's for insurance companies to be like, okay, you're doing the right treatment. By the way, most therapists and psychologists don't really care about the diagnosis. They just care about the person. And so, like, the diagnosis is really more of a healthcare system kind of thing. It's like, are we going to get reimbursed by insurance? Anyway, so if someone has complex PTSD, the right treatment would be treatments for trauma-related disorders. And when we think about it this way, when someone has a trauma-related disorder, like CPTSD or PTSD, what that is a fear of a memory. That means that you have gone through something really hard in your past that was overwhelming, that was too much of a challenge that you feel like you couldn't cope and didn't know how to cope. Usually it was like you go into survival mode and you shut down and you can't remember and you can't process those emotions in the moment. So you just shut down and survive, get through it, fight, flight, or freeze. And then only later is like, oh my God, that memory was so horrible and it affected me so deeply that I don't even want to think about it. I don't even want to be reminded of it. I want to blink it out of my mind. I want to avoid any situation that will bring up memories of that. So it's really avoidance of the memory, which is a core piece of trauma-related disorders. So a lot of the treatments for trauma-related disorders like CPTSD would be helping people cope with processing that memory and processing the feelings about it and talking about how it affected you. So it's really processing like what happened to you in the past. Let's make sense of it and let's make you feel empowered and have skills around that. So prolonged exposure is a really good one. That is a treatment where we go over the memory, the traumatic memory, over and over again in a lot of detail, which sounds really hard, but it is amazing. I've seen people, wow, I mean, I love prolonged exposure because I've seen people who like literally couldn't leave their house, couldn't go to work. They were completely shut down because they were doing everything they can to not think about this memory. And then we give them a safe place to do that. It's like, okay, let's slowly talk about it. Let's slowly repeat it. Let's slowly allow you to see that you can remember this painful memory and you're going to be okay. And usually what happens is they start to like process the feelings like, oh my God, I was so mad. I was so angry. I'm so sad that that happened to me. So that's what prolonged exposure is, like repeating that story over and over. EMDR is similar. I don't know about the recent research. That's fun. EMDR. It's the whole term is eye movement desensitization and reprocessing, EMDR. It is effective. However, at least in the research that I remember, the eye movements and the clicks and stuff like that doesn't add a lot more to what's already happening, like prolonged exposure. So prolonged exposure, you're repeating the memory, you're exposing yourself to the memory. And EMDR, you are doing that, but also there's like, I don't know much about it. There's like clicks and lights and stuff like that, and like stimulating bilateral stimulation or something like that. The research that I know is like that stuff, the bilateral stimulation, doesn't add a lot more than just like exposing yourself to the memory. But people love it, so great. Like it's effective and it works. Cognitive processing therapy is another option for people who went through trauma-related disorders, and that was actually, I was taught that cognitive processing therapy is a really good one for people with complex PTSD. Why? Because cognitive processing therapy is not about like, let me think about and repeat and expose myself to the memory. Cognitive processing therapy is like, let's talk about and think about how that trauma affected me. How did it affect the way I believe I'm worthy, that I can trust people, that I have power and control, and all sorts of how safe I am. So it's really like, let's talk about the beliefs that I developed as a result of that trauma. So when I was doing trauma treatment at Duke, and I had complex PTSD patients, and they couldn't remember what happened to them. They knew something bad happened to them, but they couldn't remember. They didn't have like one big memory of an assault or an accident. It was like, oh, a blur. I know that something bad happened. So then we did CPT, cognitive processing therapy. And that looked like there was one part where we talk about, we make an impact statement where the patient writes down what happened to them and how it affected them. So that's a little bit of the memory. But if they were like, I don't remember what happened, I'm just like, okay, you write your impact statement about generally what you remember and then how it impacted you. And then we'll work through starting to think through how you could build trust, how you can have a better view of yourself and others in the world and things like that. How can you cope better with what's going on in your life? So cognitive processing therapy is a really interesting option for people with complex PTSD because it's like, okay, fine, you don't remember what happened, or there's not one thing that happened. It was just like your whole childhood was terrible. Let's talk about how that affected you. And borderline personality disorder, that has its own set of treatments. And I've gone through that with other episodes, but the gold standard is dialectical behavior therapy. There's also transference focus therapy, which also I learned, mentalization-based therapy. DBT is always the one I recommend. That is the intensive outpatient treatment. And what that means is there's a skills group where people learn skills like how to regulate their emotions, how to deal with really intense distress, how to deal with their relationships, and mindfulness. So they learn like these skills to regulate emotions. And they also have a one-on-one therapist, and which includes like phone coaching. So that means that if they need help outside of the sessions about like how to apply these skills, like, oh, I'm feeling like I have an urge to hurt myself, and it's like, I'm at home, then they can call their therapist for that kind of coaching, and the therapist will walk them through, okay, let's figure out what skills can help you right now. So that's dialectical behavior therapy. course, I'm a big fan. It's one of the things I learned the most. Um, but that is focused on teaching emotion regulation skills. It's not as focused on let's process what happened to you in the past and the memory. Of course, memories come up, traumas come up in that treatment, but it's not like there's a part where we go, okay, let's talk about what happened to you. Um, so and so with people who like you don't know what's going on, it's really people can do with these kind of symptoms, BPD or CPTSD, they could do both of these treatments, and both of them can be really helpful. We have seen patients that were doing both. They were in our DBT program, but they also were doing trauma treatment on the outside. The way that looks is a little tricky because it's like if my husband, who has the back problem, was doing PT, physical therapy, right? He's doing things to strengthen his core and strengthen his back in order to cope better with with the problem. And that's like an everyday I'm building skills. But then if he goes into surgery, he could still do physical therapy, right? He could still do, learn how to cope, but there might be a period where he might, it's intense and he has to heal and things like that. So that's what I think about when someone's in DBT, but they also need trauma treatment. It's like, okay, we're learning skills about how to deal with your intense emotions, how to stop hurting yourself, how to stop suicidality. And oh my gosh, I'm noticing that you're having trauma symptoms like flashbacks of the memory or really intense dissociation around being reminded of it. Okay, that person might also need some trauma treatment. Sometimes we'll pause one and then send them to the other, right? And it's really about what the patient wants too. If the patient's like, I'm not ready to deal with that memory. I'm not ready to deal with my trauma. They might benefit from learning skills, right? They might learn a couple of the skills that we teach at DBT and be like, okay, now I know how to do the ice skill instead of hurting myself. And then now I'm ready to do trauma treatment. So we can mix and match here. This is not like, it's not one thing is right or one thing is wrong, but it's really a conversation between the patient and the therapist. It's really like, what is the patient ready for? What does the patient feel like they need most help with right now? What is a symptom that is blocking their progress in another treatment, right? If they can't remember, if they're dissociating and can't remember a lot of stuff, teaching them skills in a skills group is really hard. Like they're sitting there. I've had patients like this in my DBT group where they have been through a lot of trauma, like most of them have, but then in the group when I'm teaching, like, here's mindfulness and like, let's talk about this concept about what emotions are, and they're triggered and then they like blank out. And then it was like they weren't even in the class. Okay, they need to get a little bit more treatment around their dissociation and their trauma in order to participate in something else so they can really take in the lessons from the other treatment. I mean, I know. I know this episode was really technical, and it really went into the weeds of diagnosis and stuff. And I know some people are still going to be mad at me, but I just want to break down the misperception that having a trauma means that you're being validated and understood and like you are allowed to be a victim of something terrible, like your emotion dysregulation or problems with your emotions is not your fault. It's about something that happened to you. And I don't like the idea that if you are diagnosed with BPD, borderline personality disorder, you don't get that kindness and that understanding, right? I don't think that either disorder, I don't think BPD at all is a bad thing. It's really, really hard, but that's not like one disorder means is your fault and you're bad and you can't be treated and there's something wrong with you. And the other one means that you are a victim of something and you can't be treated. No, I'm not going to participate in that. So both are really painful disorders. PTSD and BPD are often comorbid, meaning they overlap a lot. The same people can have both. And there's different treatments for each one. And whether you get a diagnosis of one or the other, or whether you choose one treatment or the other, it is up to you. Everyone's healing journey and their treatment is a conversation between them and what you know about yourself and your provider. And if you don't feel like you're listened to by a provider, they're the wrong ones. Come to any of the Personality Disorders Institute or DBT. Like we love all sorts of patients, and there's a lot of amazing transformations and recovery that could happen for any of these people with the right treatment. I have seen people go from, even my complex PTSD patients, like they're blanking out and can't remember anything throughout their life, their current life. They couldn't get close to anyone. They couldn't get serious with anyone because they just felt like numb and blocked and like bad. And then like I saw them heal, process their trauma, feel sad that happened to them, and are able to put it in the past and not move on, but forgive themselves or make room for that, or know how to cope with that memory of that terrible thing happening to them. And I've seen them like go from feeling so lonely to like being married with children in ways that they never thought was possible for them. So I don't know. I'm hoping that this gives people hope and a little bit more clarity about all of these disorders. All of these disorders that come from sometimes like really, really bad trauma and really, really difficult situations. So I hope this was helpful. I almost hesitate to say this because I don't know how I'm going to talk about this, but I'm going on a healing retreat this week. Actually, I'm leaving like right now to the airport. I'm going on a healing retreat for young breast cancer survivors with plant medicine. So it is legal. It's really regulated, and it's really like a thoughtful healing process. I do want to talk about it here, but I'm going to take time to just experience and let myself heal and receive the healing and go through it. And then I'll figure out how to talk about it, because I don't want to just like jump into making such a personal journey so public, but I do want to share my experiences with you guys. So stay tuned for that. We'll see what happens and see what I can say about it. But love you all. And if you have questions or want to talk about, all of this stuff with BPD and CPTSD, you could always write in the comments. That's like the easiest way I could see, like write in the comments on YouTube or Spotify, and I could reply, because I want to know when you're listening to this, like how do you feel? Like, do you feel like, does this answer your questions? Are you still confused? Do you feel like upset by any of the things I said? I want to talk about it. So just write in the comments, or you could always email me, kibby@coolofmind.com. And if you are struggling with having a loved one with borderline personality disorder, CPTSD, whatever, and you want to help them but don't know what to do, this is why I built Cool of Mind. So it's our all-in-one program. It gives you skills and education for how to support the people that you love in your life that's struggling, and also yourself. So you could check that out, Cool of Mind, KULAMIND.com. You could book a call with me and you can talk to me directly. And if you like this episode, please send this along to anyone who would benefit. I really want to get this information out there about what these disorders are, and that there is hope about treating them. And always, if you leave a 5-star rating on Apple Podcasts or Spotify, I really appreciate it. But see you next week. Thanks, guys. By accessing this podcast, you acknowledge that the host of this podcast makes no warranty, guarantee, or representation as to the accuracy or sufficiency of information featured in this podcast. The information, opinions, and recommendations presented in this podcast are for general information purposes only, and any reliance on the information provided in this podcast is done at your own risk. This podcast and any and all content or services available on or through this podcast are provided for general, non-commercial, informational purposes only, and do not constitute the practice of any medical or any professional judgment, advice, diagnosis, or treatment, and should not be considered or used as a substitute for the independent professional judgment, advice, diagnosis, or treatment of a duly licensed and qualified healthcare provider. In case of a medical emergency, you should immediately call 911. The host does not endorse, approve, recommend, or certify any information, product, process, service, or organization presented or mentioned in this podcast. And information from this podcast should not be referenced in any way to imply such approval or endorsement. Thank you.